acromioclavicular joint resection and rotator cuff repair with augmentation, surgical tips in shoulder arthroscopy. A 57-year-old female presented with a chief complaint of right shoulder pain affecting her daily activities. There was no history of trauma. On examination, Job and Halkin tests were positive, and acromioclavicular joint was tender. Rockwood view of the right shoulder revealed a large acromial spur. MRI of the right shoulder confirmed a bursal-sided tear of her rotator cuff. There was no restriction in her right shoulder range of motion during examination under anesthesia. Diagnostic arthroscopy showed no tear on the articular portion of the rotator cuff. Attention was turned to the subacromial space. The coracoacromial ligament was released. The acromial spur and distal clavicle were exposed. Subacromial decompression was done in 2 views with the distal clavicle as a guide. The anterior portal is made just anterior to the AC joint. It is then debrided and exposed prior to resection. During resection, ensure that the burr and the joint line are parallel and do not resect more than 8 mm of the distal clavicle. The burr is put in reverse when nearing the superior AC ligament. To ease visualization, the posterior viewing portal is more medial, in line with the AC joint. The bursal-sided tear is then visualized, the rotator cuff footprint debrided, and microfracture done. A single, triple-loaded, all-suture anchor is inserted. The number of sutures in the suture anchor is increased by 1 with the following method. One of the original sutures are selected and its length adjusted, with one limb being shorter than the other. An extra suture is threaded throughout the long limb and shuttled across the anchor mechanism. This technique allows us to increase the strength of our final construct and being cost-efficient at the same time. After shuttling the extra suture through, we now have a quadruple-loaded all-suture anchor. An arthroscopic suture passer and a first-pass suture passer are both utilized to pass sutures across the tear, from posterior to anterior, as planned. This is a diagram of the suture distribution. The shoulder joint is examined to ensure no sutures have passed through the biceps tendon. The anterior tiger blue sutures and posterior tiger black sutures are knotted. This is a suture distribution after knot tying. The sutures are then divided equally and fixed with 2 lateral row anchors. This is a final construct of the rotator cuff repair, with the intact articular side acting as an internal brace. Next, a switching stick is used to determine the rotator cuff axis, and this is marked on the skin. The biologic patch is inserted along the marked axis under arthroscopic guidance and deployed. With the help of an assistant, the biologic patch is secured to the cuff with staples from the anterior portal. And a bone staple from the lateral portal. This is the view of the biological patch after secure fixation.